Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello, my mechanically minded friends. I am the Millennial Mechanical Therapist, and today we're going to talk about whiplash. So, about a month ago, I had a patient who came into my office for an evaluation with unilateral asymmetrical symptoms that went from her head all the way down to her fingers. Initially, without knowing that she had, whiplash, I thought, derangement. And, we've even spoken before a little bit about hunting for derangements and how that's not necessarily the goal of the assessment. We don't need to talk about that here. But, that was, my mind was going, derangement. So she comes in and we start talking, and then I hear that about 4 weeks earlier than when I saw her, she was in a motor vehicle accident and she's just now getting in for physical therapy. So 4 weeks, boom, done. The Institute does a very good job, and if you haven't taken any courses or listened to any of the information given out by the Institute, the McKenzie Institute, mechanical diagnosis and therapy really does stress healing time frames and what structures heal and how they heal. They stress that a lot. Not only are we trying to find out if people are mechanical, but we also don't want to do harm to our patients. And the best research out there so far for whiplash disorders really says just active movements in one or two directions, kind of like a dysfunction, pain-free or produce no worse type situations. So we go through the history. I let her give me all the information. She really doesn't have any big red flags besides that she has some head symptoms and that she feels that she had some type of concussion-like symptoms where she's been slower at thinking, the headache, that type of stuff. Now, because I work for a hospital-based outpatient clinic right now, I technically am not allowed to, deviate from my script at all, and we have to have scripts. So I told her that if, the head symptoms continue and the other symptoms get better, but they don't, we can definitely look and start treating for maybe concussion-like pathology. And to give you a little information on her, she really didn't have anything that, in the better worse section that screamed derangement. There was no sometimes. It was really just, as she moves, she gets more pain. As the day progresses, she gets more pain, and just frequent bending of the head brings on her pain. There's really nothing that makes it better besides not moving. And nothing else. I mean, sounds like it could be a derangement, right? And I'm a big proponent of putting everybody through the repeated movement testing, putting everybody through the assessment. However, due to the time frame of her motor vehicle accident, I knew I really wasn't going to be stressing those structures. I didn't want to stress end range too much on her. So we went through, movement loss. She had severe movement loss in the transverse plane and into extension. All of it was painful. She had, paresthesias down to the fingers. So I'm really thinking derangement, but I didn't want to stress her out. So for about 2 weeks, we did rotation, active range of motion, and we really educated and really spoke upon the yellow light, or the traffic light, and particularly yellow light. And I treated it as a transverse plane or rotation dysfunction, where I wanted her to, feel the stress into rotation, but not anymore afterwards. And in doing that, some of her symptoms within 2 weeks really got better. She really didn't have the paresthesias. She had pain down to her elbow right around then. Now, she was taking it really easy at home and at work. She wasn't doing any heavy lifting. She wasn't doing anything like that. So that probably, just avoidance of things that set her off probably helped as well. So after about 2 weeks, we got to about 6 weeks. And traditional healing time frames, day 1 to day 5, day 6, day 7, you're in the acute phase, right? Day 5, day 6 to about 4-ish weeks, 30 odd days, you're into repair, and then, after that, beyond into remodeling. Well, the Institute really stresses that, and they also stress, not putting these patients too hard through repeated movement exam or achieving end range or trying to achieve end range until they get out of that 6-week remodeling phase, or repair phase, sorry. So when she came in on the 6th week, within 1 week, she was actually leaving for a vacation from her family. She really wanted to go to it. At that point in time, she still had the head symptoms all the way down to her elbow, no paresthesias. And she was happy with what had happened, but obviously you can tell that everyone wants faster resolution of their discomfort. So I explained to her that it was literally like that day to the date was probably 6 weeks. And I explained to her, what I would like to do, but that we didn't want to get a red light, that we definitely didn't want to get a red light. So, with someone like that, I really try to be open with them. And I also ask them to be open with me, because we're not getting anywhere well if I don't get any information. So we go through the repeated movements exam, and to my surprise, she responded very well to retraction with self-overpressure. Wonderful. Rotation, I think she gained like 20 degrees in each direction or something absurd like that. And her pain went from her elbow to her shoulder. Boom. She was in. So she went away for about a week after that. I saw her one more day. I didn't want to change it. I didn't want to achieve further extension end range while she's going to be away from me for a week. So she went on vacation for a week and then came back. And it stayed in her shoulder. She was happy, but still wanted the rest of it gone. I think the headaches went from constant to intermittent, which she was very happy about as well, especially while on vacay with her friends. So, in my mind, I went, yes, we went from more whiplash-ish treatment to a derangement. Still with caution, because I don't want to allow a red light to happen or anything to happen in that soft tissue while it's healing, especially by achieving end range in the wrong direction. So, long story short, we went into extension and sitting, and we centralized very well, and her movements just improved like crazy, and her headache gone. Fast forward a visit or two, she's really only dealing with centralized pain and no headaches, and she's loving it. And she started doing housework again, lifting again, everything that she wanted. And she's dealing with centralized pain that, unfortunately, she's having a problem with maintenance, where it will actually kind of drift off a little bit, and we spoke upon that. But so excited, because here's a person who, came in originally with something that really doesn't allow me to pursue the assessment form in its finest and its purest. And I can't, that's fine, because, do no harm always, no matter what. I would rather take poorer outcomes to do no harm than chances on doing harm to individuals. So, but by the time healing-wise, I was able to achieve it, and kind of out of necessity with her situation. We went from having someone with whiplash disorder, which could technically take a while, to someone who hopefully will be done within the next week. So awesome. Again, I stress, this is why the mechanical evaluation is so awesome. This is why everyone deserves it. Now, in her situation's a little different. We couldn't give it to her in its purest form in the beginning, but then we were able to afterwards. So if you're treating patients after car accidents, if you're treating patients with whiplash-ish type disorders, and when healing allows, you're not trying to achieve end range, you're not trying to find mechanically direction of preference, you're not doing them well enough. You're not getting them, you're not at least looking. Maybe it's nothing. If it's pure whiplash, great, produce no worse all the way. Yellow light every day, they'll get better. It just takes time. But man, if you find someone with a direction of preference after 6 weeks, or however weeks after their accident, and they're going to be better that much more, a lot of disability goes away, a lot of fear with driving. So many improvements can be made just by trying to assess the patient when you have the ability. So, I think this is awesome, because this is an awesome, example of not being able to do the assessment form. Once we were able to do the assessment in its purest, we were able to classify her even better or more better. And now she can really go off and just live her life and get done with that chapter, put it aside. So, again, I stress everyone deserves a mechanical evaluation, even patients who might not seem like they do. Everyone deserves it in some way or shape or form. Move your patients early, move them often, and move them to End Range, my friends, because it's truly where the magic happens. Find us on Facebook. Come to our website. Let us know what you think about the videos. We hope you enjoy it. We hope you get some information out of this. We love the feedback. Thank you, and look forward to you next time.